Deepika, we are live.
Good evening, everyone. I welcome all the esteemed faculty members and delegates to another session of academic series Knowledge, Attitude, and Practices in Anesthesiology. I would like to thank Mr. Rahul Chobe from Anaesthesia TV for live streaming this session. I would like to begin with introducing our moderator for today's session on the topic simulation-based learning, who himself has made this KAP series a huge success and has connected anesthesiologists all across the nation to discuss variety of cases. Dr. Naveen Malhotra, sir. Dr. Naveen Malhotra, sir. Sir is Senior Professor and Head at the Department of Cardiac Anesthesia and Pain Management Center, PGIMS Rohtak. There are a lot of achievements under his name, but to name a few, he is Deputy Chair of AARS WFSA, Honorary Secretary, SARC AA. He has received ISA Bhopal Award for Academic Excellence 2015, KPR Young Anesthesiologist National Award 2009, KOP Award for Trauma and Critical Care 2001. He has got more than 200 publications and more than 400 presentations. Dear ISANs relate to him as our own Secretary, ISA National. His areas of interest are chronic pain management and cardiac anesthesia. We welcome you, sir, and over to you, sir, for beginning the session.
Thank you, Dr. Deepika, for those kind words.
Award 2009,
Welcome
KOP Award for Trauma and Critical Care 2001. He has got
seniors,
more than 200 publications
teachers,
and more than 400
friends,
presentations. Dear
dear
ISANs relate to him as
Today
our
we have
own
got very
Secretary,
interesting
ISA
session
National. His
of the
areas of
knowledge,
interest
attitude
are
and
chronic
practice
pain
of academic
management and
series
cardiac anesthesia. We
on
welcome you,
simulation.
sir, and over to you, sir, for beginning the session.
The importance of simulation in anesthesia
Thank you,
practice
Dr. Deepika, for those kind words.
education.
Award 2009,
Welcome
KOP Award for
all
Trauma
the
and
panelists,
Critical Care
students,
2001.
chairpersons,
He has got
additional
more
seniors,
than 200 publications
teachers,
and more
and we
than
really cherish
400
them
presentations.
today even.
Dear
Yes, that is okay.
ISANs
In
relate
that
to him as
instance, today we
our
have got
own
a very
Secretary,
serving
ISA
guidance in this
National.
particular
His areas of
knowledge,
interest
which is
are
the
chronic
application
pain
of academic
management
series.
and
Madam
cardiac
guided us in that particular
anesthesia. We
on
welcome
simulation.
you, sir, and
But
over
the
to you,
world has
sir,
changed
for
now,
beginning the
and
session.
we have to
The
go on
importance
with
of
the
simulation
syllabus.
in anesthesia
Thank you,
practice.
Dr.
Deepika, for
There is
those
emphasis on
kind
patient
words.
safety education,
Award
and we
2009,
will not take
KOP
chances.
Award for
All
Trauma
the
and
panelists,
Critical Care
students,
2001.
And
chairpersons,
He
simulation
has got more than
is an
200
excellent
publications
tool,
and more
and we
than
really cherish
400
them to improve
presentations.
the perioperative
Dear
outcomes of
ISANs
patients
relate to him
undergoing
as our
any
own
anesthesia
Secretary, ISA
session.
National.
It not only enhances the skill of the operator, but also helps the patient, because if the patient is safe, there is decreased perioperative morbidity. So today we'll look forward to our esteemed panelists with a wide variety. We will be guided by our chairpersons, Dr. Sharvari Swaikam Madam, Dr. Tilaka, Dr. Navneet Sinha. I know it's very odd time for him from Australia. It's almost 11 o'clock in the night there, but he has taken pains after his busy day today.
My pleasure, sir.
And our panelists and faculty, Dr. Naveen Palirwar, Dr. Pooja Bhiyani from Jodhpur, Dr. Habib Karim from Jharkhand, Dr. Vivek Chakole and Dr. Sudha Jain from Maharashtra, Varda. They are all here to share their knowledge, experience, and guide us for future endeavors. And we have got Dr. Anusha Cherian from Jipmar, Puducherry. So they will be all sharing their knowledge and skills with us. It has been rightly said that simulation is not a choice. but nowadays it is mandatory. It is mandatory to improve the perioperative outcome, and we should see the world not only as it is, but as it isn't. So I really look forward to this interesting session. If there are any questions or queries, you can type that in Q&A. And I also place on record deep sense of appreciation for Anaesthesia TV and Mr. Rahul Chaube for streaming it live on Facebook, YouTube, and all other social and electronic media. Thank you very much. And today the coordinators are Dr. Deepika, who will be coordinating today's session. And I also have amongst us Dr. Sunil Sethi and Dr. Neha Sinha and Dr. Amit Rana. Over to you, Deepika.
Thank you so much, sir. To chair today's session, we have with us esteemed faculty, distinguished faculty from different parts of the nation. To start with, we have Dr. Sarbari Swaika. She is DA, MD, FIME, Professor of Anesthesiology, HOD Emergency Medicine, in charge Level 1 Trauma Center at IPGMER, SSKM Hospital, Kolkata. She is past President, ISA West Bengal and ISSP West Bengal, past Vice President, RSCCP National, EC Member, IDA National, President, IAPA Bengal, and Transplant Coordinator for NOTO. Welcome, ma'am, to the session.
Thank you, Dr. Deepika.
Thank you, ma'am. Next, we have Dr. Tilaka. She is a clinical lead at Apollo Simulation Center, Chennai, ex-assistant professor, AIIMS, New Delhi, and has been awarded as Excellence in Simulation by Apollo Hospitals. Her areas of interest are translational simulation, regional anesthesia, obstetric anesthesia. Welcome, ma'am, for today's session.
Thank you. Thank you so much, Dr. Deepika.
We have with us Dr. Naveen Sinha. He is consultant anesthetist at Mackay Base Hospital, Australia, and is an honorary at Northampton General Hospital. He is a FRCA, FANZCA, FCAI, and EDRA. He has got membership of RCOA London, CAI Dublin, ANZCA Melbourne, and ESRA. He is a programmer director for International Fellowship in Regional Anesthesia, ex-recruitment and rota coordinator for junior anesthetists at Northampton Hospital and Leicester School of Anesthesia trainees. He did his anesthesia training from Wells School of Anesthesia, Cardiff, fellowship in regional anesthesia at Morriston Hospital, fellowship in upper GI and vascular anesthesia from the University Hospital, is a part of group simulation learning in safe anesthesia, and has co-organized various workshops and simulation sessions. His areas of interest are simulation in anesthesia and anesthetic non-technical skills. Thank you so much, sir, for taking out the time.
Thank you so much, Dr. Deepika, for introduction. Thank you, panelists.
As we know, nowadays, it's the era of simulation-based learning to provide learners with hands-on insights into the subject via realistic scenarios. And what's better than learning it from the experts themselves from different parts of the nation. And today we have with us experts from the field of simulation, Dr. Naveen Paliwal, Associate Professor and in charge, Dr. SN Medical College, Jodhpur. He is a simulation instructor affiliated with Pedistars, NELS and IRCF instructor, coordinator CRTC at Dr. SN Medical College, Jodhpur. He has got more than 25 publications in various index journals, and his areas of interest are critical care, airway management, and simulation. Welcome, sir.
Thank you, Dr. Deepika.
Dr. Pooja Bihani. She is an MD, DNB, FIPA, and assistant professor at Dr. SN Medical College, simulation instructor affiliated with Pedistars. Her major achievements are she has been awarded Fellowship in Pediatric Anesthesia, Gold Medalist for securing first rank in MBBS Final Prof Part 2, more than 30 research papers in various national and international index journals, has organized a number of conferences and workshops, faculty at various national conferences. She is a AHA certified ACLS BLS instructor and IRCF certified instructor, coordinator of Comprehensive Resuscitation Training Center. Her areas of interest are critical care, airway, and simulation. Welcome, ma'am.
Thank you so much, Dr. Deepika, for a kind introduction.
Then we have Dr. Anusha Cherian. She is MD, DNB, EDEC, Professor at Department of Anesthesiology and Critical Care at JIPMER. She has got more than 16 years of teaching experience, is a course coordinator for DM Critical Care at JIPMER, has achieved short-term fellowship in critical care from Australia, member of Technical and Curriculum Committee for Simulation Kerala, member Simulation Committee JIPMER, is an instructor for ACLS, ATLS, FCCS, has presented and organized over 30 CMEs and conferences, and has published 30 papers in peer-reviewed journals. Her areas of interest are critical care, sepsis, AKI, mechanical ventilation, and simulation-based medical education. Welcome, ma'am.
Thank you. Thank you, and thanks a lot for inviting me. Thank you.
Thank you, ma'am. Then we have Dr. Habib Muhammad Riazul Karim, Associate Professor Anesthesiology, AIMS, and ex-Associate Professor Anesthesiology. His major achievements are more evidence rater from McMaster University, Fellowship IANIV from Spain, and is Associate Director for BMC Anesthesiology, World Journal of Medicine, Emergency and Critical Care Medicine, Curious, Emergency Practice and Trauma. Is editorial member and reviewer of more than 30 national and international and PubMed and ESCI index journals, has more than 230 publications and 15 book chapters. He has guided and co-guided 20 postgraduates and postdoctorates. His areas of interest are NIV, human patient simulation, and anesthesia economics. Welcome, sir.
Thank you very much for your nice introduction.
We have with us Dr. Vivek Chekole. He is MD, FIPP, Professor and at Department of Anesthesiology, JNMC. His major achievements include FIPM Dardia Pain Clinic from Kolkata, PGCC Rheumatology, Certificate Course in Palliative Care, IAPAC, FIPP Budapest 2013, ex-GC member for IAPM, ISSP, FIAPM 2022, and his areas of interest are pain education. We are honored to have you, sir, on board today.
Thank you, Dr. Deepika. Thank you, Naveen, sir, for inviting me for this prestigious CME.
Welcome.
Next, we have Dr. Sudha Jain, ma'am, who is Professor at Department of Anesthesiology, JNMC Savanagi, ex-Director Professor, MGIMS, Sevagram, Varda. She has attended several conferences and workshops as faculty, chairperson, and delegate, has presented many talks and papers at SARC, national, and conferences. She is an accredited speaker of Maharashtra Medical Council, resource person for various CMEs, workshops, and conferences at MGIMS and ISA, is a postgraduate teacher and guide, examiner and paper setter for MD and DNB anesthesiology, has been a GC member of ISA Vardha for 2 terms. She is the coordinator for life-saving anesthesia skills, AMOC training, convener for awareness program in breast cancer club at MGIMS, has been appreciated by MP state government for work in NLEP. She is chairperson of internal committee against sexual harassment at workplace at International Hindi University. She has got 16 publications in national and international journals, is an active member of ISA, ISCCM, ISP, and IMA. Her areas of interest are simulation-based training and training for very operative medicine, emergency medicine, critical medicine, airway management, and palliative care. Welcome, ma'am. We are honored to have you on board.
Thank you, Deepika, for the kind words. And thank you, Dr. Naveen, for inviting me for this prestigious CME.
I would like to hand over to our moderator, Dr. Naveen Malhotra, sir, to begin with the session.
Thank you, Dr. Deepika. So I'll straightforward go to Dr. Deepika, Dr. Naveen Paliwal and Dr. Pooja Bihani to discuss about the core concepts of simulation. Over to you, Naveen and Pooja.
Yes. Very good evening, everyone. Dr. Deepika, can you please share the screen?
Yeah, sure, ma'am.
Yes, thank you. And thank you very much, sir, for giving us opportunity to talk on this important topic, that is simulation-based teaching at this national platform. As we all know, as sir also discussed, that medical education, if we talk about medical education, it has grown rapidly as an educational tool, not only to teach the technical skills, but also the non-technical skills in medicine. So for the next couple of minutes, me and Dr. Naveen Paliwal will discuss the core concepts and fundamental concept of simulation. And we will proceed each core with a real-world example. So coming with the first core of simulation, that is celebrate failure. As we all say, every failure is a step to success. And we all make mistakes and we learn from our mistakes. But with some work, the repercussions of making mistakes are okay and they're contained. But if we talk about anesthesia and such profession, even a single minor mistake may have a huge real-world impact, just like aviation industry. So how can we minimize the chances of making mistakes? Here comes the role of simulation. Here, simulation can work wonder here. It provides a platform where you can do as many mistakes as you wish, provided you acknowledge your mistakes and reflect from those mistakes what went wrong and responded to a workplace by avoiding repeating such mistakes in real world. Just if we take one example of resuscitation, can we allow them and learners to practice this on real patient? I think no. But in simulation, learners repeatedly and deliberately perform various steps of CPR till they got mastery over a resuscitation skill and each and every component of CPR, not only the technical but also the non-technical part. And if they're not performing any step properly, the facilitator tries to find out the mistakes, and the learner himself come up with the problems, with the mistakes, and come up with a solution. And when they encounter this cardiac arrest scenario in the real world, he will be responding with the less or even no mistakes at all. So facilitator helps to recognize themselves, the mistakes, and allow them to acknowledge their mistakes, reflect from those mistakes, and respond in the real world with no mistake at all.
Very rightly said, Dr. Pooja. To err is human. If we don't mistake, we are not humans. And that's why simulation comes in. This is the platform where we create real scenarios to practice the way we do in clinical scenarios. The second core for simulation is don't fix on shiny things. This principle emphasizes the importance of staying focused on essential aspects of the case or situation rather than getting distracted by non-critical details. This core highlights that fidelity in simulation does not necessarily require high cost. What do you mean by fidelity? Fidelity refers to the realm of a simulation compared to the actual clinical setting. Even using low-tech mannequins can still provide effective learning experience and valuable training outcomes without the need of expensive technologies, just by increasing realism, increasing fidelity. This can be done by increasing psychological fidelity, by adding a loud parent, the difficult parent in a scenario, or by just increasing the sound of alarms. This will increase psycholagical fidelity as if working in a real environment, or by adding the functional fidelity by using real equipments, like what we do in our simulator lab is we have marked the 2 joule on the defibrillator as 200 joules. So when we run the scenario, the participants will have the real feel of charging the defibrillator to 200 joules and deliver it. Similarly, we can add fidelity by increasing the physical fidelity. This can be increased by creating in-situ simulation, like we can change our simulator lab to the operation room environment by using those equipments, OT tables, anesthesia workstations, participants in scrubs, wearing caps and masks, hand hygiene. Also, by using simple molar gaze and probes, we can increase fidelity. So the focus would be on designing simulation that prioritize the learning objectives and provide relevant training opportunities rather than solely pursuing high levels of fidelity at any cost. We can transfer training without maximizing all three dimensions of fidelity. We can only increase one dimension of fidelity. Also can work for us. Like increasing psychological fidelity itself will give them the sense of working in a real scenario. These are the mannequins, low-tech mannequins, which we try to increase their fidelity realism by adding moulages and proofs.
Dr. Deepika, can we show the picture of using moulages and to show fidelity ones?
I think see.
Deepika, move the slides, please.
Okay, Dr. Pooja, we can continue with the next core.
So, yes, the second core concept is very taken care of. That is, we do not need high-tech mannequins and to run a simulation scenario. We can go with the low-tech mannequin, and we can create high-fidelity ones with even the low-tech mannequin. The third core concept of the simulation is stay focused on why. We can go with the third core concept, stay focused on why. In simulation, as we discussed, we encourage supportive relationship with our learners. So they come up with their own learning. It's not about we are teaching the high grade or middle school children. We are having adult learners. So we are not giving with the spoon feeding. Rather, the learners will come up from and will generate new insight by focusing on why. A simple picture which have been shown. You can see in the picture, there is a fractured shaft of femur. But by looking at the picture, if you're going with the management part of getting it fixed, it's fine. But if we are going with the simulation scenario, I will think and my learners will think why it has happened and what can be the behind this fractured shaft of femur. Patient might be in the hemorrhagic shock. There might be lots of blood loss. So he will try to go on management perspective as per the ABCDE protocol. Similarly, if I give another example, if we are teaching the advanced cardiac life support, their facilitators not only focus on the technical part of doing CPR, but they try to come up why cardiac arrest happens and what can be the possible reason behind the patient develop cardiac arrest. There may be hyperkalemia, and if hyperkalemia is there, why hyperkalemia develop in this patient? So facilitator try to extract from learner why it happened, and there's a part of simulation where facilitators extract participants to develop new dimension to approach a patient in the real world.
Yes, and the fourth core is psychological safety and accountability. This is the backbone of simulation. Psychological safety is a shared belief among team members that simulation space is conducive to take interpersonal risk without fear of negative consequences. Creating psychological safety in simulation training is essential for several reasons. When participants they feel safe, they are more likely to actively engage in the learning process. They will ask questions and they will share their perspectives openly. This enables effective teamwork, communication, and collaboration as participants feel comfortable expressing their ideas and concerns without fear of being judged. By embedding and cultivating psychological safety, simulation facilitators can foster a culture of continuous learning and improvement. Participants are encouraged to reflect on their actions, discuss mistakes, and learn from them constructively. This open and supportive environment promotes the development of effective communication skills, adaptive behaviors, and problem-solving abilities, all of which are vital for success in real clinical settings. On the other hand, accountability in simulation involves participants taking responsibility for their actions and decisions during the scenario. These participants are encouraged to reflect on their performance, identify areas of improvement, and take ownership of their learning journey. By promoting accountability, simulation facilitators help participants understand the significance of their actions in a simulation clinical context and how their decisions impact patient outcome. This cultivates a sense of responsibility and commitment to providing high quality care in real clinical scenario. So combining high psychological safety and high accountability in simulation is a powerful approach to learning. So a psychologically safe environment allows the participant to explore their capabilities, make mistakes, and learn from them without fear of consequences, as we are working in a simulation scenario. Simultaneously, accountability at the same time will recognize the participant importance of their role in the simulation and actively seek to improve their skills and knowledge. We used to give example of critical incidents reporting. This can happen only if we can generate high psychological safety, at the same time high accountability at our institution. Then only they will able to report critical incidences. And this is the same reason why we want to generate high psychological safety and accountability, so that participants, they come with their ideas, they come with their solutions for the problems encountered during the simulation scenarios.
Absolutely. Both psychological safety and accountability is must for running any kind of sim scenario and to practice our learner the skills. Next important core is work we do every day. It's about that we cannot go to run sim scenario without knowing the need assessment of our institute and of our learners. Simulation is actually a reflective teaching. So we should know the need assessment. Accordingly, we can run any kind of sim, just like cardiac arrest, difficult airway management, intraoperative complication, pediatric anesthesia, and so many. So just take an example of difficult airway management. We routinely read it from books, the difficult airway management protocol. But if we encounter a similar situation in the real world, do we go as per the algorithmic approach, as per the plan A, B, C, and D? No, sometimes because these are being taught and read from books, then we will do as work is claimed and taught by teachers and by the peer groups. Then we are brain imaging, yeah, it can be done in the particular scenario. But what happens if we fill the knowledge gap? Before running a simulation scenario, we practice all the knowledge part by video demonstration and didactic lecture. Then we come in the simulation environment where we practice not only the technical skills, but how to work in a crisis situation as a team. Then if we encounter the similar kind of situation in the real world, I'm telling you, it will reflect as like the ideal situation, because now our mind knows what actually their knowledge is and how to practice in the crisis situation, especially the non-technical skills, just like situation awareness, calling for help, leadership, that can be acquired by the sim scenario. And we should practice all these things just as the work we do every day.
Yes, truly said, Pooja. We retain only 10% when we see. We retain 30 to 40% when we see and hear, but we retain more than 90% when see, hear, and do it. Yeah. Like the next core is the transaction. This core enables participants to bridge the gap between the theory and practice, promoting meaningful skill development and preparing healthcare professionals to provide safe and effective patient care in a real-world setting. That is from skills to behavior change. That is from conscious incompetence to unconscious competence. That is being aware of the skill but not being proficient in the skill to being to perform skill automatically. That is behavior change. We used to give example of hand hygiene at our institute. We had taken this hand hygiene as a basic skill for all simulation scenarios. Whenever there is a deviation, whenever the participant, they don't practice hand hygiene, we'll pause the scenario and we'll debrief it and we'll run the scenario. Because of this repeated practice now at our institute, all these healthcare workers working in our ICU, they practice regularly hand hygiene, and this has become their habit now. If they don't want, also they will automatically do hand hygiene in our ICUs.
Yes. And the next important concept of simulation is the power of reframing. Actually, simulation provides an environment where we look at the same problem with a different angle, and we are creating the threat to an opportunity. Just an example, as Dr. Naveen earlier said, the critical incidents reporting of any kind of scenario. Not only my department, but at everywhere, some adverse events are happening, and it's natural. But are we reporting all the events? We are not reporting all the events because if without reframing, what happened? the department or the person would consider it as a threat to reputation. Am I being blamed? Or then they feel overwhelmed and will try to focus this blame game on some others. But what happens with the reframing? We encountered few situations in our institute. Then we try to report the situation, and then we try to find out the root cause of the problem, why that the CICU situation happened in our institute. And then we incorporated the simulation training for airway management for anesthesia provider as well as faculty, and it refined their skills and improved their decision making. So by the simulation and by using this power of reframing, we can change the culture of threat to the culture of opportunity and provide better care to patients.
Yes, very rightly said. Threat to opportunity. Simulation gives us this opportunity to make our threats into our opportunities. The next core concept of simulation is know your learners. This is a critical principle in simulation-based education that emphasizes the significance of understanding the unique needs and goals of each participant. This core principle recognizes that learners come from diverse backgrounds and have different levels of experience, knowledge, and learning style. So before planning any simulation session or scenario, we need to go for need assessment. Need assessment can be done at the level of organization. It can be done at the level of experts and at the level of learners. The most important need assessment will be at the level of learners. We need to know their basic knowledge. We need to know their skills, and we need to know their mindset before planning any simulation session. The next and the most important thing, if you forget all these codes of simulation, just remember one thing: love your learners. If you remember this, your simulation journey is started. When you love your learners, you will be transparent, you'll be empathic to them, you'll be open, you'll be honest, you'll be compassionate, and you'll be curious to teach them. So the summary of our course is love your learners. Now we welcome you to the local anesthetic systemic toxicity scenario simulation. In this scenario, we'll be exploring a critical and time-sensitive medical emergency that occurs during local anesthetic administration. The purpose of this simulation is to provide a realistic learning experience for healthcare professionals to practice, identify, and manage LAST in a safe and controlled environment. Before we begin, let's take a moment to review the learning objective for this simulation. Recognize the signs and symptoms of local anesthetic toxicity, initiate appropriate intervention promptly and effectively, demonstrate effective teamwork and communication during a high-stress situation, and practice critical decision-making in a time-sensitive clinical emergency. We have with us Dr. Anusa Chirai, ma'am. Ma'am will guide us or elaborate us for the preparatory part of this scenario.
Thank you, Dr. Naveen Palewal and Dr. Pooja Bihani, for discussing the core concepts of the simulation. And I must appreciate the good coordination between both of you when you were discussing about the core concepts. So I'll request Dr. Anupacharian to please join. In the meantime, I'll invite the chairpersons, Dr. Tilaka, Dr. Navneet Sinha, or Dr. Sarviswaika. A few words from your side, madam. Dr. Anupacharian, please get ready with the presentation.
Sorry, ma'am.
So thank you all the speakers, Dr. Palewal and Dr. Bihani. You have explained the whole thing is a very nice way, the core concept of simulation. This is very nice concept. These are the concepts are very nice. Just one thing I would like to ask, what is actually, one thing is very important in the definition of simulation, that is the experiential learning. So what is that actually? What if you kindly share with your experience, this thing, like experiential learning is a part of simulation. It's
ma'am, simulation is something we are trying to create the clinical scenario in a controlled environment.
Yes. That is true, and there is active process. No, it is an active process between the learners and the trainers,
yes,
who are. There is sharing of knowledge, and it's a construct of the experience and construct of the learning process.
Ma'am, it's more of a getting solution from participant itself. We give them a real scenario as if they are working in a real clinical situation and facilitate facilitators are there only to steer the scenario. They will only guide them. Rest all the queries or the solutions and the problems all will be given by the participants. Learners will come up with their problems, they will come up with their solutions, and they will come up with the take-home message. Facilitators are only there to smoothly run the scenario. If there is some gross deviation, they will come in picture and they will again run the scenario on the learning objectives.
Yes, yes.
So yes.
Thank you.
Thank you. So beautifully done. I don't think we've ever heard such a beautiful discussion of the core concepts, and that too so very well coordinated between the both of you. And rightly pointed out that we are not there to teach, we are actually allow people to learn. So they are two different things. And in particular, I also love the fact that the both of you emphasized a lot about simulation not involving cost, simulation not being a technological advancement, and simulation actually being a technique of teaching, which means it could be done anywhere, it could be done using anything. It's just a technique. Also, another thing that I really liked about the talk, and I would love to re-emphasize, is the psychological safety that gets created for the learners to learn, which eventually we are looking at translating into the clinical area, where they would feel psychologically safe when something happens, so that a system means there will always be some kind of improvement that is required. A system means there will be something that would always have to be added. So we just want the learners to be psychologically safe, even in the clinical environment. I don't think anything can be added. Everything was very beautifully brought out. Congratulations. Over to Navneet.
Thanks, Dr. Naveen and Dr. Pooja. Excellent introduction to the topic. I think you kind of covered all the core topics, actually, but I really liked a couple of things, actually, when you said a few things about the anesthetic non-technical skills like fixation, which is very common, actually, in our practice. And why is it important to anesthetists? Because when we make mistakes, there's a life at stake. So simulation has much more bearing in our practice as compared to other specialties. At the same time, everything leading to behavioral change. That's what we are aiming for, actually. And I love the word, love your delegates, actually. So if you love them, you are empathetic towards them, then you know actually what their learning objectives are. It can be individualized, actually, and see how they can improve in a session. Of course, they have to take back everything to their own practice. But then we teach concepts. And these concepts, if they take it back, it's excellent improvement. Even in a day, you can make a difference. So excellent. Thank you.
They're the only small things that make a great change. That's a concept behind simulation. Yeah. So
thank you, Pooja and Dr. Naveen Paliwal. So now we move on the scenario-based discussion. Our scenario today is local anesthetic systemic toxicity. And we have got Dr. Anusha Cherian amongst us, who shall be talking about preparations for the scenario. Over to you, Dr. Anusha Cherian, please.
Is my slide screen on? Slideshow?
Yes.
Yeah. Thank you. So good evening, everyone. I thank the organizers and Dr. Naveen for inviting me to participate in this series this evening. So as we all know, today we are discussing a scenario-based discussion on LAST. And in the next few minutes, I will be touching on general principles while we prepare for a scenario, and highlight on how we are going to prepare specifically for LAST. So, scenario creation is fundamental to simulation. So an effective design is necessary to optimize training, and we no longer need to emphasize the effectiveness and the need for simulation-based education, as it has been extensively studied, and it is becoming an essential part of postgraduate curriculum. So, the objectives of creating a scenario building is to provide an opportunity for the trainees to learn how to manage common cases as well as rare case scenarios, to better prepare them, of course, for examination as well as for real life situation. And so in order to do this, we need to create, especially in a last-like situation, we need a high-fidelity simulation which requires assembling of all the elements to recreate a realistic environment while considering the different learning styles of the learners and the different levels that the learner must be in. So ultimately, our goal is to help to improve the knowledge, skills, and attitudes while the person develops confidence in gaining these skills. So eventually, the goal of simulation-based education is to improve performance in the real life. So while the scenarios are scripted in a certain way, and we expect the scenario to unfold in a certain way as we would expect in real life, we know that our trainees are at different levels of learning, so their actions can be unpredictable and cannot be going like what we expect. So we should be building in flexibility during the scenario. And also, depending on how the trainee is responding, we should also be able to alter the complexity of the case. I'm sure all of us would have had the experience like when in a Viva candidate is doing very well, we keep stepping up until a point that he cannot answer, but that is not the aim for this. We will be doing within the learning objectives, and safely and carefully we can alter the complexities, and appropriate distractions need to be incorporated in this. And whenever possible, try your best to incorporate interprofessional communication. This simulation is a very good environment in which you can actually, they are called embedded persons or actors, where faculty and technicians can act as nurses and other doctors. And so the person can actually learn how to interact with these people in a high-risk situation. So how do we go about developing a scenario, and what are the strategies and processes for this? So designing a scenario can be a very daunting task. And without a scenario development process and a team that is in place, it is going to be very difficult. So very important to have a dedicated team who know how to run a scenario, how to make a scenario, and then we can have other faculty coming in to give in their inputs. So, and then another very critical thing that has been emphasized earlier as well is to have a critical step is to know who your target audience is, target group is. So to identify the level and the educational needs that they have, and that the needs that are most relevant to the learner. And this forms the basis of writing the objectives. So scenarios which skip this crucial step would end up resulting in objectives that are inappropriate for the level of the learners, which would lead to frustration both in the learner as well as the facilitator. So it's like setting a very simple scenario for an experienced team, or having a highly complicated case for an interns group. So this would lead to frustration in both the groups. So in other words, target the learner's needs and not the facilitator's wants. So for this, we need to invest time and recognize the needs of the learner. This may require formal needs assessment of the learner, and we need to really work on these. And always try to incorporate crisis resource management strategies for this kind of simulation. So how do we formulate goals and objectives? We need to, like I said, we need to have a needs assessment, basically to find the gaps in the knowledge, attitudes, and the skills that are there in form of questionnaires, group discussions, observations. We find their strengths and their weaknesses. So broadly, what are goals? Goals are like broad, general content. They give a direction in which the teaching proceeds. While objectives are, they have to be specific and we should be able to measure them. This has to be coming in the methodology when you plan the scenario itself. Be sure not to include more than 3 to 5 objectives per scenario. Specifically, you need to say who will do what and how well by what time. So this would be like a PG year 2 will do or perform or discuss what he will do. It has to be specified. How well? Is he going to be under guidance or independently? So what level of competence you want, and by what time? Like, is it at the end of the session or after a week or after several sessions? So these need to be identified. What domain you need to focus on. And as we all know, simulation can incorporate all 3 domains. And also try to incorporate individual competencies as well as team level competencies when you plan the scenario. So rough learning objective would be like the PGY2 should be able to identify signs and symptoms of local anesthetic toxicity in the patient, administer treatment for the local anesthetic toxicity, understand the risk factors, why the patient developed the anesthetic toxicity, develop communication skills during crisis situation, identify and probably try to find out the safety methods to prevent such occurrences. Then in detail, we can say at the conclusion of the scenario, this resident will be able to identify the signs, symptoms of mild, moderate, and severe toxicity, will be able to manage mild, moderate, severe toxicity under guidance. They should be able to discuss and implement safety strategies in order to reduce the incidence. So this will be part of your debriefing, which again, you will have to design into your preparatory scenario itself. What are you going to concentrate in the debriefing? Like the participants themselves will come out, what knowledge they had, what prior experiences, the experiential learning. So what they had in the prior sessions that had helped them to come out with these kind of strategies during the course. So all these would be planned in the debriefing sessions. And also how effective, what are the resources they have, and what kind of resources are lacking, the weaknesses, all these would be coming in the debrief, which need to be planned earlier. So we would be targeting the medical knowledge, the practice-based learning improvement, the interpersonal and communication skills, and system-based practices. Like we will be identifying the key weaknesses in the response system and what kind of clinical environment we have, what needs to be strengthened. All these can come up in these scenarios, which we need to priorly discuss and keep ready. Another important thing is to keep your resources ready. What resources you need to develop in the beginning itself. Who are the faculty? What audiovisual agents need? Very important to have technicians. I have seen many programs fail because there is no one to take care of the equipment, keep them in running condition, work them during the scenarios. So these form a really important part. And time is very important because most of us are running busy schedules. So we need to allot time to practice, to train. All these need to be built in. And another important thing, like I said before, confederates or embedded persons. These are very important, whom we are going to make as actors to facilitate the simulation, where we are going to conduct it, whether it's a hospital situation or inside the operation theater, and how the scenario will be set up. Now, coming to equipment. So fidelity is a very important aspect of simulation. So especially in a situation like simulating a local anesthetic toxicity, we need a high fidelity. I don't mean a high-tech equipment, but what all we create there. So what we basically want to do is we want a simulation to suspend disbelief. So it should mimic reality, to feel authentic. So what are all the concepts, conceptual, these physical, the psychological things that you can think of to include to improve this kind of fidelity? So simulation experience, as we all know, is characterized by the environment. That is, it's experiential, it is interactive, it is collaborative, and it is a learner-centered thing. So we are trying to buy or suspend the disbelief, and we are trying to promote the engagement of the student in the learning process. So you can have monitors that are beeping, alarms that are going off. And so it creates a kind of a real operation theater environment. That is called the real psychological fidelity. So this situation, like the last, would need a real operation theater environment creation, and a set of equipments and monitors that we need to keep ready and functioning should be there with us. This is not an exhaustive list, but a few of them which we need for this situation. Then coming to the scenario development, these can be divided into 5 phases. We can have worksheets to work on. So the first is the pre-brief session, where we will be dealing with expectations, confidentiality, the scenario orientation, how the patient is, the background information, baseline, steady state. Then comes the scenario states. Like during scenarios, we have phases. There are states, around 3 to 4 states, which will be the learner will be moving through these. So what triggers the movement from one state to the other? What experience is needed in each? What are the roles? All these need to be identified earlier. Have a pilot run, definitely. And during debrief, what are to be brought out, what the learner has to revise and review, all these need to be done. And important to have an evaluation at the end of it. How did your scenario go? How did the learners perform? Did any learning happen? All these need to be done in the report. So touching briefly about scenario planning, the whole storyboard as such would be lasting for 15 to 30 minutes. So in this pre-brief would last for 5 minutes. Most of them, as we know, would be new to simulation. So you need to introduce a concept of simulation, tell them what are their objectives and goals. We need to tell the specific goals of this scenario when we tell them, but we should not be telling all the objectives, because this is to prevent, keep the element of surprise in it. So you would be saying, induce this patient, but you will not be, the goal is to induce the patient, but you will not actually tell what is going to happen during this induction. So during this pre-brief time, you also take time to orient the person to the simulated environment. These are the monitors, the equipments, what people you have, what resources you have, what is the limitation of your simulated environment. And then we need to emphasize the confidentiality, that whatever is happening here is going to stay within the room, and so that there is no threatening of their learning. There should not be a threatened learning environment. And we should emphasize whether this is an educational part or are we using it for assessing the people. And pre-planned learning assessment tools have to be discussed with them. And each case scenario would begin with a STEM at the beginning. So here basically a description of the patient, including demographics, what has been done until now, the labs, vitals, everything would be displayed. So coming to scenario development, there are phases. There are probably 4 to 5 states. What causes the change in phase has to be what response in the learner would trigger the state to go from one to the other. What will the learner see? What learning outcomes? The ideal flow that we expect. What are the decisions? And what are the learner anticipated mistakes that can occur here? And if there are mistakes, how do we deal with these? What are the branching points? How to keep the scenario running? What are the critical steps that the learner should not miss? What are the critical errors that should be noted if it happens? And take active learning. What are the learner's interaction with the environment and other staff? So a rough worksheet would look like this. We describe the state, the patient, the patient, that is the simulator, what it will do, what the learner is expected to do, what the facilitator is expected to do, and what is the teaching point at each stage. So beginning state is the baseline. Probably you've given the block, or a labor epidural was administered to a pregnant lady. So already this has been done. Patient is on the table. How is the patient now? And so the learner has to start examining the patient, gather all the information necessary, interact with the nurses and doctors, and the facilitators has to provide these information and answer to whatever the person is asking. And this here we need to emphasize on the rapid assessment, whether the person is learning about this rapid assessment. What are the triggers? Probably time would be the trigger, 3 to 4 minutes you give and go to the next. Next phase would be a neurotoxicity of state. Here, seizures might be that the mannequin itself might have a seizing moment, or if it doesn't, then the prompter or the facilitator has to say that there is seizure going on. The critical steps here would be to call immediately for help. If the person doesn't do what to do, should the nurse call? So all these need to be emphasized. Then how to support the airway. Then the drugs. Once these drugs are given, probably that is a trigger for moving to the next state. So what the learner has to do, and then the teaching points here would be to tell that even if you don't have if you have a negative aspiration, you could still have a negative test dose, it could still result in in the intravascular administration. There could be peripheral vasodilatation and a decrease in the blood pressure. And what were the challenges of the team approach? So similarly, you go through the cardiotoxicity phase and the recovery phase. And during cardiotoxicity phase, we might have to say, if it's a pregnant person, ACLS in pregnancy also can be incorporated here. Then coming to the pilot run. So it is important to practice the scenario in advance of the actual session to ensure that the transitions in the states are happening smoothly, the equipment is functioning well, your support staff is available, labs are ready. And during the runs, we would come to know of different things that we were not even considering during writing of the scenarios. So very important to have this. Debriefing, again, as I said earlier, have a plan for debriefing. What is the methods for evaluating the learner, faculty, and the environment in the evaluation. Different types of evaluation are available. Kirkpatrick's levels are one of them. So to summarize, to create a scenario, we need to understand our target audience and their educational needs, set specific learning objectives to suit your students with appropriate evaluation methods, prepare adequately to suspend disbelief, have a good team of invested resource persons, create workflow sheets, make them flexible, adaptable, varying complexities, practice. So coordination between facilitators, simulation, and technologies is essential for a simulation to meet the educational objectives of the learner. So this is what we have in our setup, our simulation going on. And that's it from me. Thank you so much for listening.
Thank you, Dr. Anusha, for excellently elaborating about the preparation and planning of scenario.
Thank you.
Without much ado, I'll move on to Dr. Habib Karim for running of this scenario. So it will be a complement to your talk, what you have discussed. So over to you, Dr. Habib, and then we'll take up the questions in the chat box.
Yes. Good evening, and thank you very much for giving me the opportunity. Actually, my previous institute had the skill lab. Recently, I have changed the institute and it is in our pipeline. So moving ahead, I have got good help from the team of DMIHR, which is Datta Mega Institute of Higher Education and Research. Of course, I have to thank Professor Dr. Vivek Sakle sir, Dr. Jui Ashok Jadhav, also Dr. Sudha Jain and Kirti Lonkar, faculty of SELSC Simulation Experimental School of Experimental Learning and Simulation Center. And of course, without technical assistance, as Madam said, it is not possible. So we have to also thank the biomedical engineer Joy Londe, Shraddha Jadhav, and also the in charge of the lab Sagar Khode. Thank you very much for giving me the video, for putting in the slide. So moving ahead, there are learning objectives that Madam has already said, but as we have to respect the learner, and today's audience, there will be many people who are even novice to simulation. So although I am going to run the scenario, the term used, 1, 2, 3 term used as state, that is technical term, the trigger, state, transition. So please ignore them. Just let us understand that what we want to learn is we want to learn how to proceed with running a simulation scenario in a high fidelity mannequin, and we will run the scenario of last. So please note, the discussion on CPR, if required in this scenario, will not be done, as Madam said, because there are two scenarios. One scenario, special scenario in our situation. One is pregnancy, and another is local anesthesia systemic toxicity. Both of them need some modification in the ACLS protocol. So it is not within our scope, it is beyond our scope of today's lesson. So when we proceed with running a scenario, we know the course, we know how to prepare it, environment it. There is something with pre-briefing and ice breaking. Why ice breaking is required? As we know that we all may not be knowing each other. We may be coming from different different college, different places. So to get a good team, we need to know each other. We have to break the hesitancy between each other. So that is why the breaking the ice is required. Next comes pre-briefing, is preparation and briefing. Then once pre-briefing is done, then we go as a team member with the different responsibilities and start the scenario flow. And after that, we also, assessment is actually a continuous process. Then after that, we go for a debriefing. So to keep it simple and understandable to the even postgraduate students of the first year or second year who has not got hands-on simulation yet. So pre-briefing actually is given for review of the session goal and objective. And in the previous lecture, it has been well described what is our goal in local anesthesia systemic toxicity. That after this scenario, we should be knowing how to identify them, how to respond to them in time-bound manner, what to do in immediate phase, what is to be done in the next phase. So as that is what our goal and objective is. Then it comes fictional contract. As again it is said in the core and the preparation that actually we do it in a mannequin, but we need to have a contract that it is as real as possible. Like if we make the simulation hall like operation theater or labor room, if we give the anesthesia machine card, defibrillator, airway card, it will mimic the as real as possible. If we can give a pregnant tummy to a female patient, or if we can give a wound where blood is flowing, it will mimic a real scenario as possible. That is called fictional contract. Then we also need to describe the logistics, especially the logistics related to the convenience. Where is the different instruments? What are the different equipments? What are the different wards? Where you will get water, where you will get help, where to go if you have a sudden emergency or any call. And this will also help the learner to get easy going or to accustom to this scenario, and their apprehension will be taken cover. Then place to respect is mostly for facilitator. It is not for learner. Say it is the respecting our learners. So learners are likely to have their own decision based on their scenario. They might not recognize it as a last. They might recognize it as anaphylaxis. They might think it might be simply another complication. So we should not be saying that, no, why you have not identified it. In fact, we should ask that why you have thought it. Then we should give a feedback in a positive manner, and we have to help them and respect them their decision, what it is. So learning objective of today's scenario is that we shall be able to identify the local anesthesia systemic toxicity, and we should be able to differentiate it from the other common complications which can mimic it. We should be able to respond to the patient's condition. What is the immediate action needs to be done? What is the initial management needs to be done? And what is follow-up management needs to be, if any. So here is the case. A 26-year female, 160 centimeter, 70 kg, having history of preeclampsia, and has come to labor room. And she is in severe pain, active labor. And patient complains that I cannot bear the pain. I need some analgesic technique. And she knows that about liver analgesia, and she has demanded liver analgesia. So initial assessment of the patient condition is done by the nursing officer and the resident. And as a resident of anesthesiology, epidural has been placed, but unfortunately she has not given knowingly she has not given the test dose administered, considering the preeclampsia. So in the initial assessment, again, state 1, this term is again technical. It is used for the initial condition. We use in the software to make different states, then going from one state to another, transition, and the trigger, time, or some intervention by the learner. So please ignore the term state 1. So in the initial phase, the patient, the GCS is 15/15. Patient is in pain, but it's still calm and oriented. Heart rate is varying from 88 to 92 per minute, regular and no normal sinus rhythm on the ECG. Respiratory rate is varying from 24 to 30 per minute. It's normal pattern. BP is 140/90 millimeter of mercury. Chest and CBS is within normal, and fetal heart rate is also normal. The variation is also there, which is contraction, and this variation is also normal. So what happens in the initial, that epidural has been placed and the patient has demanded liver anesthesia. Patient is saying that I am having pain. Please give me some drug. And the resident injects some epidural drug. So moving forward, epidural drug has been given and it has been informed to the patient that, okay, I have given you the drug, the effect will come soon and pain will go. But however, after a few minutes, patient is saying that, no, I am not having relief of the pain. I am still having the pain. Please do something. So as patient is complaining and you are thinking that the effect is not adequate, so the second dose is again given within short span. Within 4-5 minutes, another dose is given and it is again a loading dose in the epidural is given. So meanwhile, after the second dose, so patient says that, no, I'm feeling like tinnitus. I'm not feeling good. Do something. I'm feeling like something is, my head is spinning. My ear is ringing. Please do something. And the obstetric resident, she also does the Doppler of the fetus and for the continued assessment. So on the meanwhile, the technician says, the technical assistant of the anesthesiologist says that the monitor is giving some alarm. Please see that there is some changes in the there in the monitor. Please see, have a look. There is some arrhythmia is coming or some heart rate saturation is falling and BP is also falling. So you can find that the patient is not responding. There is also some convulsion. Patient has initially said that there is some tinnitus, and now patient is having that some bradycardia and desaturation and hypertension. So we expect in the meanwhile learner to do some initial work on this, respond to this. And what we expect that the resident who is on the head side ask for help or respond to the desaturation or respond to the ABCs. So meanwhile, if the resident responds, then we can temporarily improve the saturation. Suppose oxygen has been attached. So that's trigger that the saturation has improved. Some fluid has been given, some amount of BP has increased, but it will be transient because we have to run the scenario. And we have to go to the next state. And it may be a time bound that after 2 minutes, we think that within 2 minutes, the learner is not doing something what is supposed to do. Then time will trigger the next transition and next we'll go to the next step. And meanwhile, the gynecologist informs who has done that Doppler that fetal bradycardia is there and even NST is not reassuring and they need to go for cesarean section, emergency cesarean section. So in the state 3, you can find that patient says that resident learner need to do the ABC. She should ask or he or she should ask for the help from the senior people. So these are the learning objective. Learner should find the problem and should respond by themselves. And we should just only facilitate that what is going on, what to be done next. So once the resuscitation has been started, the airway, breathing and circulation needs to be taken care. And meanwhile, the gynecology resident also called the senior gynecologist for emergency cesarean section and patient goes to the operation theater, which is attached to the labor room. So emergency and CS is planned Meanwhile, the vitals and others also further deteriorates, and patient's ECG screen shows ECG flat, plethysmography not showing any curve, and no respiratory or other response are found. So in this state, there will be another transition to the another state. So that state, we should also expect that learner will do something in this state. And that is what that learner should do. So if the patient has collapsed, as there is now it is in the cardiac arrest phase, we expect the learner to go for starting cardiopulmonary resuscitation. Of course, again, as I said, this is a pregnant woman and having likely to have some local anesthesia systemic toxicity. So although we are still evaluating the patient, so the modification of the ACLS protocol, some amount is required as per the patient's need. So meanwhile, the baby is delivered and patient is intubated and connected to the machine. So once the patient is intubated and connected to the machine, the ECG, the monitor will show that it is CO2 has come. The compression will be shown, the compression related, the effectiveness of compression, high fidelity mannequin even can sense the quality of the CPR. According to the quality of CPR, they can also increase the BP. What about the systolic BP and what about the carbon dioxide? And they can also sense the tube, ventilation, air, lung inflation, everything. So once the tube is placed and the other CPR is started, the ventilation and the monitor, high fidelity monitor, will automatically improve those parameters which is supposed to improve. However, cardiac arrest will not end until and unless it is triggered or some specific intervention related to the cause, etiology of the cause that cardiac arrest is happening. So meanwhile, the senior person has come in the state 4 and she is thinking, or the team is thinking that this is most probably a local anesthesia systemic toxicity because the patient had a prodromal neurotype problem. Then patient has suddenly bradycardia arrhythmia, which is like cardiac symptoms of local anesthesia systemic toxicity. And also meanwhile, from the history of taking that local aspiration was done from the epidural. However, local anesthesia, that test dose was not given. 2 bolus dose is given within very short time, and likely that it has gone intravascular and it has caused some systemic toxicity. So it is thinking that it is a local anesthesia systemic toxicity. There is some specific actions are required from the team. So the learner will start some specific action. And once the specific action is started, suppose intralipid injection, then only we will after some time trigger the going back to next state, that is recovery state. So once we trigger the recovery state, obviously after cardiac arrest, patient is not supposed to have normal sinus rhythm. Patient will have some tachycardia. Patient will have some low amount of BP. Initially, it can be higher. So again, the ETCO2 graph will be somewhat escalating, slowly increasing. So it is not exactly depicting the recovery from the CPR ETCO2. So once the patient recovers, then we finish the scenario and we go for next follow-up action. What follow-up action is required for to do with the patient, whether patient needs ICU management, whether needs some targeted management. And after that, we will go for stoppage of the running the scenario and we'll go for debriefing. Thank you very much for bearing and having patience. Of course, I have to go a little bit faster because time is almost complete. Constraint is there.
Thank
so
you.
I hope I could.
Thank you, Dr. Habib, for running the scenario excellently. And yes, thank you to Dr. Vivek and Dr. Sudha and their team also for sharing the scenarios of their institute. So, Deepika, you can share your quickly one slide, and then I'll invite the panelists and the chairpersons and Dr. Vivek for the subsequent discussions, and Dr. Pooja and Dr. Naveen Paliwal for the debriefing importance. And so definitely this is an important clinical thing, which Dr. Habib will also agree. Dr. Deepika, can you write down?
Yes, sir. We must remember the lipid rescue in case of a last scenario, that is 20% intralipid emulsion. It should be immediately given as an IV infusion at the rate of 1.5 ml per kg over 1 minute and start an IV infusion. A maximum of 2 repeat doses can be given. 5 minutes apart if there is a continued cardiovascular instability or there is a cardiac arrest, and maximum 3 doses are acceptable, sir.
So I hand it over back to the chairpersons and the panelists to take it forward and interact among themselves, and especially about the debriefing. And then we'll invite Dr. Sudha Jain to share her videos of the overview of the SIM zones. And over to you, Naveen, Paliwal, and Dr. Pooja.
Thank you, sir. Thank you, sir. Debriefing is the heart of simulation where actual learning occurs. For successful learning to occur, the dynamics between the facilitator, the learners, and the other participants are vital to ensure the safe reflective practice. One should choose appropriate debriefing method based on the type of learners and the type of simulation experience being delivered. We'll try to explain debriefing in a discussion manner with Dr. Pooja.
Yep.
So to start with, we'll first select the sitting arrangement. A sitting arrangement is very important for debriefing. It should be either circular or a semicircular with the facilitator sitting amidst to the participants. First thing we have to do is we have to acknowledge that it is a simulation, and then we'll proceed with gap analysis AI. What do you mean by gap analysis AI? That is grading with reactions. What do you mean by with reaction? Like I'll ask Dr. Pooja, how did you feel being in this scenario?
I just felt like I was managing this case in the real world, just a patient in which I performed labor epidural and the patient developed local anesthetic toxicity. I just felt like I am just doing it as in the real world. But at some time, I felt overwhelmed also, whether I would able to manage this patient properly or not.
Yes, the facilitator should be patient enough to listen to this reaction of the participant, because this is the phase where we'll come to know what learners actually wants to talk or wants to learn, right? After this reactionary phase, we'll ask one of the learners to summarize the case so that there is no confusion among the participants about the case scenario, what actually is the case.
Yes.
So,
it was a case.
So Pooja, can you summarize the case for us?
It was a case of local anesthetic systemic toxicity after performing labor epidural in a young lady at term pregnancy.
Okay, great. So after having the medical facts of the case, we'll go for the analysis. For analysis, we have plus delta charge. That is, we'll ask the learners what went well and where we need improvement. For this, we can prepare a plus. Plus is what went well, and delta is where we need improvement. And these reflections will be coming from the participant itself. We can prepare a chart with the reflection from the participant, and we'll make them themes and we'll put on the whiteboard. Like a few things which went well. Pooja, can you elaborate?
Yes, in the scenario, there was early call for help, and there was immediate recognition of the local anesthetic toxicity by recognizing the signs and symptoms of neurological toxicity, and there was effective leadership among all the participants regard to the role allocation and leadership. Yeah.
Okay, great. So great. We can frame them, right? We can frame that early call for help was there, effective team dynamics was there. They recognized local systemic toxicity early. So all this went well. So what are the areas where we need improvement?
I think there was some delay in administration of intralipid. And second, patient condition, deterioration in the patient condition was not communicated with the patient's relative.
Yes, great. So there is some human factors also, that there was no communication about the deterioration of the patient's condition to the patient relatives, and there was delay in administering intralip. Further, what we do, we carry out some of these phrases for detailed discussion. Like I'll ask Dr. Pooja, I observed that there was delay in administering intralipid to the patient, and this may lead to the deterioration of the patient's condition. So I'm curious about why this delay has happened.
Actually, I was so much concerned about managing the neurological signs and symptoms at that time. Patient developed cardiac arrest also. So that's what is my mind, whether I would be able to resuscitate the patient. There are so many things. So I could not prioritize the things, and that delayed the administration and call for the intralipid administration.
Okay, let me see if I understood correctly. You have many things to be done. So you were not able to identify these things to be done at a priority, right? Yeah. So this can be generalized to the rest of the learners if they had similar situation during their clinical postings. If they have some similar situation, they can discuss with us. And with those similar situations, then we can ask the learners or the participants to come up with the solution for this problem. So what can be done, Pooja? So how can we overcome this situation?
The team leader can prioritize the role allocation and ask each and everyone clearly what has to be done at that particular moment. Like he could have asked another person to go for intralipid and the third person to administer and start an infusion for it.
Yes, exactly. That means this priority has to be set by the team leader. He needs to give small instructions, not a load of instructions to the participant, so that he can do his work efficiently. Great, very great. So now we would like to have one take-home message from all participants. We'll start with you, Pooja. Can you tell us one take-home message from this scenario?
Yeah, early recognition and timely administration of intralipid whenever you recognize local anesthetic toxicity.
Yes, very important. One more which I want to add is healthcare providers should not only monitor vital signs, but also maintain the verbal contact with the patient while performing nerve blocks, right? So that he can early recognize the neural toxicity, local anesthesia, systemic toxicity. Another we can add is there should be availability of 20% lipid within the OR where we regularly use local anesthetics for blocks, right?
Yep.
And at the end of the debriefing session, we'll ask the learners what system change they will like to make at their institution after going from this simulation session. So can you just tell me, Pooja, what is the system change you would like to do?
I would make a local anesthetic systemic toxicity kit, last medication kit, and it should be available at each and every OR complex where LA are being used.
Yes, great. So we can introduce a last kit in OR, not only the availability, but everyone should know the location, where is it available. So what is debriefing? Debriefing is to observe, advocate, inquire, then repackage it, generalize, then develop a solution to it and design system change. This is all about debriefing in post-event scenario.
Excellent, Dr. Naveen and Dr. Deepika and Dr. Pooja for that. All the issues pertaining to debriefing. I just only want to reinforce debriefing is not fault finding. It is to analyze the problem and suggest the possible solutions and improve the outcomes. Before I hand it over to the chairpersons, Dr. Sudha Jain and Dr. Vivek Chakole, over to you for running the different sim zones which you have in their institute, and you can run the videos and say a few words also. Dr. Vivek Chakole and Dr. Sudha Jain.
Yes, Sudha madam will run the video. Till that time, I will elaborate the challenges for this running the video. The first and foremost challenge is always the technical challenge. Can you hear me, sir?
Loud and clear.
Yes.
So first and foremost is technical challenge. So we have a plan A for recording the video that fails. So we have to go for plan B with other camera we have recorded so that we can at least record the video. So there is always technical issues. Logistic issues are there because we have the human patient simulator, which is male simulator, and we have to run the scenario for the pregnant lady. So we have and we cannot run this on SimMom or Juno. So SimMom is mid fidelity and Juno is low fidelity. So we cannot run this scenario with all the hard change and changing drug and the parameter changes, it is not possible. So we have to make some arrangement for so that we can deliver the baby immediately, and like that we can do. That is the second challenge we have. So, and third is always the performance anxiety. Performance anxiety is always there for each and everybody, because this video will be showing in some good platform, and it should be good. So performance anxiety is always there, and there is some time pressure is there. We have to do this in this span. We have to do this in this span. So it is difficult to do all these things. We have change in patient perception and simulation perception. So we have to mingle these perception. So in our institute, we are making this mandatory for undergraduate students and postgraduate students, so that they can sustain with this simulation environment. We are creating some scenarios according to their level, and so they can run the scenarios, and we are daily posting them for this simulation lab. And so we have seen in our clinical department the improvement of the simulation lab. So it's a mandatory. So we have to change our mind from routine, because simulation is the future, and परिवर्तन ही संसार का नियम है. So we have to change from this real environment and to the simulation environment. We have to train the students, faculties for the simulation environment. We have to motivate the clinicians for this, because better clinician also say that why I should waste my time in this. But it's not wastage of time. It's beneficial for ourselves and for society also. So thank you very much, the KAP team, Naveen sir, for involving us, our setup for this academic activity. Right, Sudha madam can run the video.
Yes.
Thank you, Dr. Vivek, and I must appreciate the good setup you got in your institute, and I think Dr. Sudha again will be able to show it in the videographs or the videos also. Over to you, Dr. Sudha then, madam.
Yeah. Good evening, esteemed faculty and all the dear delegates. Yes, please. Yeah. Today I will be talking about the overview of the SIM zones at our Jawaharlal Nehru Medical College under DMI-HER, that is the Tamegi Institute of Higher Education and Research. It is a deemed to be university. The facility here is called as Anukriti, and our punchline for that is Skill to Heal, School of Experiential Learning and Simulation Center, that is SEL and SC. So this simulation-based training at DMI-HER started since 2005. I think it's quite early, the idea was perceived. And now we have outstandingly high quality and unique program in full environmental facilities. This simulation training has been beneficial, as Dr. Chakole has pointed out, to our anesthesiology residents and faculty also, and similar and similar specialties who handle medical emergencies with fresh and insightful perspective on how to deal with the medical emergencies. Our simulation lab has 3 zones, that is low fidelity zone, mid fidelity zone, and high fidelity zone. And the effective communication, emphasis at SEL is at the effective communication and cooperation to develop skills and collaborative habits learned through active participation in an simulated experiential environment, because the best way to learn is through experience and complete immersion, that which is made possible at our SEL and SC simulation center. The purpose of the skill lab, as as per the document of NMC, which was released on October 2020, which states that all medical institutes should have a skill laboratory, that is simulation lab, with specified design and planning for the capacity of that institute, means number of the medical students, undergraduates and postgraduates available at the place. Accordingly, the size and design has to be planned. Where students can practice and improve their skills, which is pre-specified as per the competency-based medical education curriculum, and it has to be in safe environment, non-threatening, to learn, practice, and students are observed while performing skills. Specifications in our SEL-SC at JNMCR, the School of Experiential Learning and Simulation Center, that is Anukriti, DMI HER Savangi Vardha, is Central India's largest, most comprehensive, state-of-the-art, multidisciplinary medical simulation center. It is spread over more than 12,000 square feet area and equipped with state-of-the-art, high-fidelity patient simulators. It is an initiative of DMI HER to serve as a center of excellence, imparting skill training to healthcare professionals with defined objectives. Our low-fidelity zone has many task trainers, including which start from IV arm. The students are allowed to practice IV cannulation over those arms. Then IV injections are given. Then subcutaneous injections are practiced. Central venous catheterization under USG guided environment is available. Then HA recommended BLS mannequins ranging from neonate, neonate, pediatric age group, and adult are available. Skin and leg suturing mannequins are also there. Breast inspection simulators are there. Gynecological examination model, catheterization training lab, wound care and bandaging simulators are there. Then there are special task lab also using USG guided mannequins, USG guided central line insertion trainers, USG guided regional anesthesia simulation modules like for brachial plexus block, USG guided lumbar and thoracic puncture, epidural catheterization trainers, which are very useful for our anesthesia residents. Then basic medical and procedural skill labs, chest drain mannequins, ICD insertion mannequin are also available, abdominal paracentesis, spinal epidural simulators, episiotomy trainers for obstetric users, and cadaveric well-equipped virtual lab is also there with 3 full-equipped operation stations and C-arm compatibility on the operation OT tables. In the mid-fidelity simulation lab, we have array of simulators available. The first and foremost is ARIES, ACLS mannequin with pre-hospital emergency care providers. Then nursing NE, which for nurses basically to hone with the nursing skills training programs. Then trauma care for ATLS training and bandaging, etc. Then ventilation training modules are there. Maternal and neonatal training, premature infant mannequins. But our most prestigious recently bought mannequin is Zuno, which is a high mid-fidelity, but it matches with a high-fidelity mannequin, which is a clinical skill training mannequin, which offers better preparation for clinical competencies to undergraduates as well as postgraduates and to nurses also. It also gives combination of basic and advanced scenarios. It helps to prepare learners to thrive when they enter challenging hospital environment. Real fluid administration can be practiced on that, and vital signs monitoring is a prided feature of that. The realism of these mid-fidelity mannequins provides opportunity to the students to think critically during simulation practice. And then our center is equipped with a large number of high-fidelity mannequins, and first and foremost, I will talk about this HPS, which is the very high-fidelity mannequin and owned by very few institutes in our country, which is full form human patient simulator. The simulator supports anesthesia with cardiovascular, respiratory, neurologic, and pharmacological modeling. High fidelity simulation has inbuilt technology to mimic physiological changes like reactive eyes, palpable pulse, heart sounds, breath sounds, bowel sounds, etc. HPS has realistic upper airway, which allows laryngoscopic intubation, and also difficult airway module can be practiced on that. Can perform needle cricothyrotomy, needle thoracocentesis, and pericardiocentesis also. Then there is a SimMan, which is very useful for teaching our undergraduates. It is also high fidelity because clinical, it's combined need for identify skill improvement areas of individual as well as those essential for team to function together, such as communication, behavior, because two-way communication is possible through this mannequin also. And it simulates various medical emergencies that may occur under anesthesia, emergency medicine, ICU or trauma department. SimMan interfaces with real clinical monitors like ECG, defibrillators, etc. And very good demonstration of normal and abnormal bowel sounds, normal and abnormal heart sounds, respiratory sounds is possible with precision with this mannequin. Then for obstetricians and gynecologists, we have got SimMom, where they can demonstrate a normal labor, abnormal labor, like breech delivery, and they have collapsing obstetric patient is there that can be very well simulated, different scenarios for collapsing maternal collapse. And there is a version of operation theater as well, which is very useful for upcoming surgeons, because it is a very technologically advanced mannequin where the actual hand-eye coordination with perfect debriefing, where they are, because it is a psychomotor skills development mannequin, which gives you perfect training opportunity to develop the surgical skills to the surgeons, and particularly that laparoscopic procedures. Then US Mentor for radiological procedures with there's an ultrasonography simulator for radio diagnostic skills enhancement. The basic and advanced skills can be practiced. Here we have got even transthoracic echocardiography and transesophageal echocardiography probes, which can be attached and which can be useful for cardiologists as well as a point of focus ultrasonographic assessment for other clinicians, like sometimes even anesthetists need them or emergency medicine physicians need them. Then we have got our pride position, that is anatomies, which is a virtual dissection mannequin and atlas. It has got 3D view of all anatomical planes and all organs, and even histopathological correlations of the various organs can be done through this anatomies. And it can be studied, the anatomy of the human body can be studied through various planes and various angles through this anatomies. So this is how our, apart from that, in our skill lab, we have got virtual patient program infused with Mayo Clinic. It has started with internationalization because the leading centers in the world are collaborating with our institute for simulation-based training. And Mayo Clinic, they are training our faculty as instructor as well. And in December this year, they are planning to give this instructor course to this institute. And then virtual cases based scenario practice is also done, which is collaborated with Weill Cornell College of Medicine from USA. So here also our institute is doing a standardized patient simulation, and case based scenarios are run for the learners' advantage. Then we have got international collaboration with AHA, for BLS and ACLS training. So this is how our center is working, and with the mission to generate skilled healthcare providers to cater to the diverse needs of the society by adopting simulation for augmenting clinical proficiencies, imbibe professionalism, and apt attitude and expertise in communication skills. Thank you, everybody.
Thank you, Madam Sudha Jain, and for briefly running over all the SIM zones in your institute and the work being done. So I hand it over to Dr. Navneet Sinha to carry it forward along with all the chairpersons and the panelists. Over to you, Dr. Navneet Sinha, please.
Thank you. Thanks, Dr. Anusha, Dr. Habib, for excellent presentation. Dr. Anusha, you went into in quite well detail in all the domains actually how to prepare for a scenario. Because of the time constraint, I had a few questions. I'm not going to go and ask specifically, but I'd like to just make a few points actually. Looking at the questions we are getting from delegates actually, that it seems the theme is same, asking about how to inculcate simulation in their PG courses. And ma'am's presentation says actually, as per the National Medical Council, we have to have medical institutes have to have simulation centers. Unfortunately, I don't see that coming in next couple of years or few years. It will come. Eventually, it will come. But what do you think actually, this is a question for Dr. Anusa actually. What do you think actually that in the meantime, what we can do actually to make it easily accessible to not just postgraduates? A lot of us work as a freelance anesthetist, and that's kind of extreme situation where we haven't got a team to look after. We can't ask for seniors to come in. There are no seniors there. So we have to work with whatever team we have got, and team is surgeons, scrub nurses, runners. So like I've been coming and running these scenarios and sim sessions for 5 years. And what I find actually, these conferences are the good place actually. If we can organize sim workshops, we get very good response actually, and most of them are very grateful actually if we can run this thing. But of course, the ideal world would be to get them in a postgraduate curriculum and every medical institute to have their own sim centers, as Sudha ma'am presented.
Yeah, so thanks for the question. So I'll take it in two parts probably. One is the postgraduate education, and the other is what do we do about the rest of the people who have already crossed their post-graduation state and they are probably working elsewhere. I believe that's the question. So our students, what they need, I believe we know that. But these others, we would have to find out what their needs are. We need to know what they actually want. Just because we have a setup and we do this kind of simulation at one place, we cannot expect everyone to want that kind of simulation. So basically, we need to assess what's the needs for these other adults who want to learn. So I think that would be way forward. And as you rightly said, workshops right now is the way that we can do. And I believe a lot of centers are doing that. They are conducting a lot of workshops, and that is a good thing to go ahead, I think. And patient safety things are coming up as well, workshops. So, yeah.
I would like to add a little bit with Madam. Actually, I'm sure that Sir Naveen Malhotra sir also remembers that this problem was felt by us and even ISA and sir also, Malhotra sir. And we wanted to train different institutes, residents and practitioners. In some institute, actually, I took AIIMS Raipur skill lab. Unfortunately, I have left that institute. That we will train them with minimal fees, so that they can come at the batch in the Saturday or Sunday or some holiday time, in a batch of 28 people or something, and the ISA will also somehow help them to sponsor them to some extent, and that institute also will run it as a non-profit basis, more or less some staff related and some equipment related, some fees will be taken out. So we sorted out and planned such a training solution, training session as well. And I hope that this can be taken up by different institutes. Different institute has now different skill labs, especially INI, and even that Sawangi is also an excellent center, and many other centers, even Pondicherry, JIPMAR, PIMS, and I think another institute, and also they are also having good, even Dinkar Paisar, I think he was also there in Pondicherry only. He also has a good lab there. And probably we can collaborate from the ISA side and the institution side. And ISA can help us, our PGs and the practicing anesthesiologists, especially in this issue.
I endorse your views, and ISA is seriously working, and it has been approved also to have centers of excellence. The ISA endorsed skill centers across different parts of the country, so that the delegates, the students, the practitioners, they can come to the institute nearest to their place. They don't have to travel too much. And it can be a win-win situation for both the institutes also, the delegates also, and the Indian Society of Anesthesiologists also. The institutes have invested such a huge money, manpower, space for these setting up these simulation centers, simulation labs, and it will be pertinent to give hands-on training, simulation-based, to as maximum people as possible, primarily for so many reasons. As I've told, to increase the patient safety, to improve the skills of anesthesiologists as perioperative physicians, and also to have ROI also. So at the end of the day, you have to have return of investment, and to make it a sustainable model. As you rightly said, no profit, no loss basis, and once in a month, once in a 2 months, because we are all busy clinicians also, or we have got a dedicated staff to teach these delegates. And I'm very sure soon we will be inaugurating the such center at AIMS Raipur, and it will be opening to the numerous other skill centers which are endorsed by ISA as centers of excellence. Like suppose somebody is in Puducherry, why he need to go to Delhi? So they can come and learn in Puducherry. Those who are in Chhattisgarh, they can come and learn in Raipur. Those who are in and around Maharashtra can go to the Varda. And same way they can come to Gurgaon in Haryana or Delhi in those who are in that particular state. And over the weekend, they can learn the areas of their own choice, whether it is transvascular echocardiography or transthoracic echocardiography, or it is the supraglottic airway, second generation, or fiber optic bronchoscopy, or any, you name it and you have it. Chronic pain blocks, USG guided blocks, airway, and you have different simulations. Naveen Paliwal wanted to say something.
Sir, I just wanted to clarify one thing. Fidelity doesn't mean high tech or high cost. We can even go with low tech mannequins by increasing fidelity with the routine things. Like we can even use task trainers for training these potent learners in their skills, by just increasing the psychological fidelity, by increasing the physical fidelity.
Absolutely. One more thing I just want to add. We should also focus not only the technical skills, we should focus on the non-technical skills. If we are going with the teaching simulation-based learning, we should, technical part can be taken care of many times, but the non-technical skills is very, very important to go with the simulation-based scenario learning teaching.
Absolutely right, Dr. Sinha, carry forward, Dr. Tilaka and Dr. Sarburi to join. It's over to all the three chairpersons.
So, can't agree more with everybody. Actually, there are two things. One is skilling. The second is scenario-based training for non-technical skills. So for skilling, already most of the colleges would have the basic airway mannequin. There are a lot of mannequins available. So at least in my institute, we have made it mandatory for postgraduate students to come into simulation. So they have a curriculum set, they have to come in. So it's just, I know, because it's not yet a mandate from any of the bodies, there might be some kind of a resistance, but it is because there are so many passionate teachers all around India, it would really become, so we could start with things that are possible, that are already existent. And then once we show them that, yes, this is kind of making a difference to patient care, we can start probably investing more on the skilling bit, But for the simulation, like pointed out by Dr. Naveen and Dr. Pooja, absolutely no investment is required. It's only a technique that has to be learned and moved forward. For want of time, there were a lot of things that I had noted down, but I'm not going to touch on most of it. The only thing that I want to tell is excellently presented by all the panelists, and we are anesthesiologists. Like we deal with patients who are crashing. We deal with the most advanced of machines. So learning simulation is actually not too difficult for us. It might sound, if we are not in the simulation field, all these things might sound a bit too technical, and we might feel a bit hesitant to start, but it is absolutely not like that. We could start small. We could start with simple scenarios. We can make mistakes. We can make mistakes as facilitators, and we can learn. So the idea is for as many enthusiasts to start doing simulation and to embrace simulation, so that like we will have a huge community of like-minded people who are working towards patient care. That's it from my side, because we are already running too late, and there are a few questions which have been answered. Over to Sarbari ma'am.
Thank you, Dr. Naveen Malhotra sir, for inviting us to this very beautiful our today's session, that is simulation. Yes, we have also skill lab. It's not, we don't have any high fidelity simulator or like that. But we have started with low fidelity, like CPR trainer, airway trainer, and these things, IV trainer, intramuscular, intravenous, skin suturing, all these things we have. Basic thing is, and all the speakers are very good. They have explained everything very well. We should have the skill lab for every institute, and undergraduate. Now the undergraduates also have to come to the skill lab to have their minimum skill on CPR, on IV training, on central venous line, and other things. And postgraduate students should also come for some high fidelity simulation. Also, not only that, from skill lab, from simulator, we can also have our communication skill. It's very necessary whenever we are facing any problem during treating a very ill or crisis, whenever we are managing a crisis. So in that phase, the communication skill is also very important. This is what. Thank you, sir.
Madam, thank you. Before I go back to Dr. Sinha, Dr. Meghna, Dr. Nazia, and Dr. Shrivani Selja wants to express themselves. Please unmute yourself and go ahead. Dr.
Good
Meghna,
evening,
please.
team. Hi, I'm Dr. Meghna from all the way from the south. I'm the chief coordinator at AXIAN Advanced Comprehensive Clinical Training and Simulation Center at Yanapoya Medical College. That is in Mangalore, Karnataka. So I'm really happy to listen from all the stalwarts of simulation, and we've been a part of simulation-based medical education since 2016. So we do a lot of in situ simulation, sir. Basically, seeing for internal disaster management, conducting code yellows, and in theater in situ simulations, because we have seen that it really helps us in identifying the latent errors, and also interprofessional team communication. And it's something as simple as during CPR. So we had a lap cholecystectomy. As soon as the pneumoperitoneum was instituted, the patient crashed into asystole. It was something as simple as the student did not check that the table was working at all, and they were not able to give the CPR appropriately. So we simulated this in our simulations and in the theater with an in situ scenario, and then we found out the latent error that this table was not going up and down, the theater table. Something as simple as that was identified, and I really am a proponent of in situ simulations. Thank you.
Thank you, Dr. Meghna. It was a pleasure interacting with you. Dr. Nazia, please, from Noida. And then I'll go to Dr. Shrivani Selja Country. Dr. Nazia, you can... Okay, basically, I think what she has typed in the chat box was that they are also running a simulation center in the Government Medical College at Noida, and they would like to collaborate with ISA over that. And Dr. Srinivani Selja had expressed. Yeah, Dr. Srinivani, please go ahead.
Good evening, sir. Thanks for the session. So I would like to share my participation in the recent vast vital anesthesia simulation training, which was powered by WFSC. It was started in around just before the pandemic, and it focused on non-technical skills involving any situation, whether it is OT or district hospital scenarios. See, we are all posted in district hospitals also, certain anesthesiologists. So how to manage with low resource centers or peripheral private medical colleges, which might not be so well equipped with ultrasounds and all that. So what decisions you're going to take? So all these things were also a part of the curriculum. There are various scenarios which were involved. It was not just obstetrics, it was pediatric burns also, it was trauma also. So there were too many things, and it was done very well. The thing is that we need to spend a lot of time training the facilitators. It was about 5 days involvement for the facilitators, and I hope everybody is able to hear me.
Loud and clear.
Yeah. So this is not a very easy thing to arrange simulate, because first of all, the facilitators should understand what all things, as rightly pointed out by Anusha Cherian ma'am, there are too many things to be prepared with. The various scenarios, if you are doing a 3-day course to train the undergraduates or the learners. So if you want to train them and love them or love the learners, you need to first understand the whole how to go about everything. So it is a long duration thing, 5 days for training the facilitators about how to train the people who are going to attend. So this has to be, and it is a way ahead. And I really feel that this is how it has to be incorporated in the PG training, so that in the interest of patient safety, of course, because we can't learn everything on the patient in an emergency crisis situation. That's what is simulation about. So this is the way ahead. And every conference, every workshop, maybe we need to plan, chalk out. ISA is anyway supporting. So it has to be worldwide. It has to be countrywide effort. So that's my input. And I'm really happy that these things have started in India too.
Thank you. Thank you, Dr. Srinivani. Yes, we have to keep on discussing these things at wider and bigger platforms also, so that they reach. And the mindset changes that, yes, it is not an alternative to the classical teaching and training, but it complements the classical teaching and training of our very revered teachers. Dr. Naveen Malhotra, please.
I'm just going to conclude actually by saying a couple of points actually. So like take home message from the whole of this event has been actually that safety is primemost for us. And to be safe, we have to incorporate, as you said, classical teaching, traditional teaching, which we have been doing, and this simulation-based teaching. And everything comes from patient safety actually, because simulation came from aeronautical industry. Because look at the mistakes if they commit. Not just one patient. We can make mistakes, one patient dies. If they make mistake, the whole plane goes down. So they do this simulation on a regular basis, actually, almost every week. And they do it for a long period of time before they're allowed to actually do their proper work. Of course, we can't do it actually because our postgraduate training is for 3 years. But if we incorporate that quite early from PGY1, and then keep doing it repeatedly, it's not by attending 1-day course or 2-day course. We have to keep repeating it every year by year. Even as an adult, like senior anesthetist, we have to do this again and again. And the other point I wanted to make, actually, everybody's talking about is teaching the trainers. We need a lot of facilitators. So I think way forward in future, we have to train the trainers. There has to be more courses about training them actually, so that they can go back and train their postgraduates. I'll conclude by saying this.
Thank you, Dr. Navneet Sinha. And I think we are now 8:30, so 45 minutes. We have overshot, but I'm really thankful, especially to all the panelists and the chairpersons, the delegates, but especially to Dr. Sinha, because you're joining from Australia, and I understand now it will be 1 a.m. there. And if I'm not wrong, 1 a.m.
Yeah, I'm okay. It's a pleasure being there actually. So it's good to have all the panelists to listen to.
And thank you, Dr. Sarvesh Waika ma'am and Dr. Pilaka, and all the very, very dear Dr. Naveen Paliwal, Dr. Pooja, Dr. Anusha Cherian, Dr. Habib Kareem, Dr. Vivek Chakole, Dr. Sudha Paliwal, Dr. Sudha Jain, and thank you, Dr. Deepika, for coordinating this session. See you all soon for the next KAP Academic Series session. Thank you very much.
Thank you, sir. Thank you very much, sir. Thank you. Thank you so much. It was a really nice session. So nice of you. Thank you, sir.
Thank you so much.
Thank
Recording. you.